Today, we are going to tackle one of the biggest challenges in our entire field, the anesthetic management for an open repair of an abdominal aortic aneurysm. You know as well as I do, these are incredibly high-risk patients undergoing a high-risk surgery where literally every single decision we make can change the outcome. So we're going to walk through a modern, evidence-based approach that weaves in the latest ERAS protocols, all with one goal in mind, giving our patients the absolute best shot at a great recovery. Let's get into it.
But, before we dive in, I just want to start by speaking directly to all my fellow anesthesiologists out there. To all of you, thank you. We know what it's like. We know the pressure of keeping that difficult patient safe through a brutal surgery. And I just want to recognize the incredible life-saving work you do day in and day out.
All right, so here's our game plan for today. First, we'll set the stage by really defining the clinical challenge of AA. Then, we'll build a solid framework for how to systematically assess risk. After that, we'll get into the exciting stuff, how ERAS and prehabilitation protocols are completely changing the game before the patient even hits the hospital doors. Then we'll get to the heart of it, our anesthetic techniques and how to manage those nail-biting intraoperative crises. And finally, we'll tie it all together with advanced pain control and how it all fits into that complete ERAS pathway. So let's kick things off with part one, really understanding the beast we're dealing with. Look, to manage these patients well, we have to have a deep, intuitive grasp of not just the aneurysm, the big bulge in the aorta, but the systemic disease it represents. We're talking about the whole patient and the unique storm of risks they bring with them.
And that brings us to the most important question right off the bat. When a patient with a AAA rolls into our OR, what should be flashing in neon lights in our minds? What are the things that are truly going to decide if they walk out of the hospital or not? I'll give you a hint. It's not just about the size of the aneurysm.
The real answer, the core of the problem, lies right here, in their comorbidities. And AA is almost never a solo problem. It's a giant red flag for systemic atherosclerosis. It's a sign that the plumbing is bad everywhere. And our patients, they almost always show up with this full house of issues. Now look at the top of that list, ischemic heart disease. It's there for a reason. It is, without a doubt, the single strongest predictor of postoperative mortality. But all the others, bad lungs from COPD, struggling kidneys, high blood pressure, they all paint the same picture. We aren't just managing an aneurysm. We're managing a patient whose entire vascular system is fragile and compromised. That's the challenge. And the stakes, well, they could not be higher. Just look at the difference between elective and emergency surgery. It is night and day. When we have time to plan to optimize the patient, we can get that mortality rate down to a respectable 2 to 5%. But if we wait, if that aneurysm ruptures and they come in as an emergency, the mortality rate explodes to over 50%. It's a coin toss at best. This is exactly why we do this surgery. An untreated aneurysm, once it gets bigger than about 5.5 centimeters, has a terrifyingly high chance of rupturing within 5 years. Our job is to be the safety net, to get that patient through the elective repair and prevent that catastrophe from ever happening. So knowing those incredibly high stakes, we have to get really good at sizing up the danger. That brings us to part two, risk assessment. How do we move beyond just this patient is sick and systematically identify and, more importantly, quantify the specific dangers for each person in front of us? This methodical assessment is our superpower. Let's really break down this table because it's crucial. I like to think about it in two big buckets. First, you've got the patient-centered factors, the cards we're dealt. We've already talked about IHD being the big one, but right behind it are things like advanced age and pre-op renal dysfunction. Why? Because they tell us about the patient's physiological reserve, or lack thereof. They tell us how well they can handle the massive stress we're about to put them through. Then you've got the second bucket, the surgery-related factors. This is our domain. The aortic cross-clamp time isn't just a number. It's a direct measure of how long the entire lower half of the body is starved of oxygen. And where that clamp is placed, that's even more critical. A suprarenal clamp, above the kidneys, is a whole different ballgame than an infrarenal clamp. It puts the kidneys and the gut in serious jeopardy. And of course, every minute of surgical time and every cc of blood loss just pours fuel on the fire of every other risk factor on this list. Okay, identifying risks is important, but it's passive. How do we get in the ring and actually fight back? That's what part three is all about. We're shifting from just assessing risk to proactively crushing it. Using enhanced recovery after surgery, or ERAS, and prehabilitation. This is a total mindset shift. It's about preparing the patient for the marathon of surgery, not just showing up on race day and hoping for the best.
Prehabilitation isn't just one thing. It's a whole strategy, and it starts weeks before the patient even sees the inside of a hospital. Think of it as having 4 pillars. Pillar 1, education. We manage their anxiety, set realistic expectations, and get them on board with quitting smoking and drinking. They become part of the team. Pillar 2, medical optimization. This is where we bring in the cavalry, cardiology, pulmonology, nephrology, to get the patient in the best possible shape. Pillar 3, and this is a game changer, nutrition and exercise. We are literally building up their physiological reserve, their strength, their ability to withstand the hit. It's like training for a prize fight. And Pillar 4, getting anticoagulation right. We need standardized protocols to manage these meds to avoid both catastrophic bleeding and deadly clots.
So you might be asking, does all this extra work actually make a difference? Well, take a look at this data. This was a really smart study that compared 80 patients who went through an ERAS protocol with 80 similar patients who had standard care. The results are just wow. Look at the top 3 rows. The ERAS group went home sooner, they used way fewer opioids, and they cost the hospital less money. That's a huge win for efficiency and for the patient's recovery. But here's the most important part. Look at the bottom 2 rows. There was no difference in major complications or mortality. This is the proof. ERS is not about cutting corners or taking risks. It's about being smarter, more proactive, and optimizing recovery safely.
Okay, the patient has been prepped, optimized, and now they're rolling into our house, the operating room. This is where all that pre-op work pays off, and it directly influences the choices we're about to make. So let's get into part 4, the real meat and potatoes for us, the actual anesthesia for the open repair. We're going to look at the different techniques and the crazy intraoperative challenges that get thrown our way.
All right, let's really sink our teeth into this table because it gets to the absolute core of our anesthesia decision-making. This is a head-to-head comparison. General anesthesia by itself versus a combined GA plus a thoracic epidural. First, the good news for the epidural. Look at the opioid use. The epidural groups needed less than half the fentanyl interoperatively. That's huge. And it pays dividends after surgery too. Better pain scores and less morphine needed in the PACU. So on paper, it looks like a slam dunk for pain control. But, and this is a huge but, look at the hemodynamics. The GA alone group, they cruised along with higher, more stable blood pressures. The epidural groups, they suffered from significant hypotension, with their MAPs dropping below that critical perfusion pressure of 65. This perfectly captures the devil's bargain of an epidural and AAA surgery. You get fantastic pain relief, but you pay for it with a massive sympathectomy that can cause terrifying hemodynamic instability. Not to mention, these things can fail up to 40% of the time. It is a true double-edged sword. Now, just a quick detour, because you're going to see more of these complex cases. It's the pararenal AAA hybrid repair. This isn't your standard open and shut case. It's a 2-parter. First, they do an open surgery to bypass the arteries to the kidneys and gut. Then, in the same sitting, they do an endovascular repair, an EVAR, to place the stent. From our chair, this is like the perfect storm. You get all the massive fluid shifts, blood loss, and stress of open surgery, combined with the special demands of endo, like needing controlled hypotension and dealing with kidney-toxic contrast dye. It is one of our toughest anesthetic challenges.
But whether it's a standard repair or a hybrid monster, the single most dramatic, predictable, and terrifying moment of the entire surgery is the aortic cross clamp. So let's move to part 5 and just focus on this moment of controlled chaos. If you don't understand the physiology here, you can't succeed. It's that simple. Let's walk through this timeline because it plays out the same way every time. At T0, the surgeon calls out, "Clamp on." Instantly, the heart is pumping against a brick wall. Afterload goes through the roof. You get brutal hypertension above the clamp, and the heart's oxygen demand just skyrockets. This is when MIs happen. Then, for the entire clamp time, everything south of that clamp is dying. It's running on fumes, producing tons of lactate, potassium, and all sorts of nasty inflammatory stuff. Then, the moment of truth. The surgeon says, "Clamp off." Suddenly, systemic vascular resistance completely vanishes. All those ischemic vessels open up, and all that toxic sludge gets washed out into the main circulation. The result? We call it reperfusion syndrome. You get profound hypotension, a wicked metabolic acidosis, and a stunned, depressed heart. Our job is to be 2 steps ahead of every single stage of this violent cascade.
This table really sums up what we call the two-body phenomenon. It's the perfect description. Above the clamp, you are managing a patient in hypertensive crisis. Afterload, preload, CVP, PCW, everything is sky high, putting insane strain on the heart. But below the clamp, you're managing a patient in profound shock. There's no pressure, no flow, just worsening hypoxia and acidosis. It's literally like we're managing two completely different patients in one body at the exact same time, and our every move has to account for these opposite states. So, in the face of all this physiological chaos, how do we protect the vital organs? Here's our playbook. Number 1, goal-directed fluid therapy. This is a tightrope act. Too little fluid, and you worsen the ischemic injury. Too much fluid, and you drown the already strained heart. We need dynamic parameters, not just CVP. Number 2, hemorrhage management has to be flawless. That means Cell Saver is running from the start, we're fighting to keep the patient warm to prevent coagulopathy, and we know exactly who to call to activate the massive transfusion protocol. Number 3, renal protection. The key is maintaining that mean arterial pressure above 65 or 70. Mannitol or furosemide are often used, though the evidence is still debated. And finally, and most importantly, cardiac protection. Keep the beta blockers going, have your vasodilators, like nitroglycerin, ready to go to knock down that afterload surge when the clamp goes on, and have your inotropes mixed and ready to support that stunned heart the second the clamp comes off.
So we've fought our way through the intraoperative battle. Now, in our final section, part 6, we're going to connect everything we did in the OR directly to the patient's recovery. The choices we make about pain and fluids have huge downstream effects, which is why a modern, opioid-sparing pain plan is the absolute cornerstone of a successful ERAS pathway.
And that brings us right back to the epidural. For decades, it's been hailed as the gold standard, and the pros are real, no doubt. The analgesia is second to none, and it dramatically cuts down on opioid use. But we've seen the data. The cons are just as real, and they are serious. That risk of profound hypotension is a massive problem in these teetering patients, and that's before you even consider technical failures or the fact that you can't even place one if the patient is coagulopathic from massive blood loss. Add in the tiny but catastrophic risk of neurologic injury, and you have to ask yourself, is this really the best choice for every single patient every single time?
And this is where it gets really exciting. This slide is our modern opioid-sparing toolkit. Thanks to ultrasound, we have an entire arsenal of powerful and safer alternatives. A paravertebral block can give you a dense block, but because it's more one-sided, it causes way less hypotension than the total sympathectomy from an epidural. An erector spinoplane block can give you broader coverage that might even help with that deep visceral pain. Then you have things like TAB and QL blocks, which are fantastic for the incision pain and have almost zero hemodynamic side effects. We can then layer on top of that a continuous catheter dripping local into the wound, or even a systemic IV lidocaine infusion to fight inflammation. This is multimodal analgesia at its best. It lets us build a custom pain plan for each patient, stacking up the benefits while minimizing the risks.
And here is the grand finale. This is how it all fits together. A true ERAS protocol isn't a checklist. It's a seamless pathway. It starts weeks before surgery with prehabilitation. It carries right through the OR with our smart, opioid-sparing techniques, our goal-directed fluid therapy, and keeping the patient warm. And it flows directly into the post-op phase with aggressive goals for getting the patient up and moving, eating, and using scheduled non-opioids. Every single step is designed to do one thing: reduce the body's stress response to surgery and get the patient back on their feet faster.
So I want to leave you with a question, a provocative one, that I want you to really think about in your own practice. We've seen the evidence. We've seen the incredible power of epidurals, but also their very real, very dangerous hemodynamic risks. And now we've seen the rise of safer, effective regional alternatives that fit beautifully into a modern multimodal ERAS pathway. So given all of that, as our skills and our understanding evolve, is it time we finally challenge that old dogma? Is the routine, automatic use of a thoracic epidural for every open AAA repair an outdated practice? It's a question worth asking before you see your next case.